ever get a good telemetry, like simple 4-lead tracing with a LifePak 12, and we still carry our 10s on the truck. So I would do a 12-lead with the 12 and then put them back on the 10 for simple telemetry. We'd roll into the ER with the patient on LifePak 10 and the ER doc's like, did we not just spend all this money on 12-lead capable monitors? I said, yeah, but they don't do well with 4-leads.
Yeah, we went straight from LPs to Zoll M series, whatever.
Yeah, so when I went to Watauga,
What is he
we had
talking
Zoll
about?
M and then Zoll E, and then now everybody's using it.
What? I like that 5. I'm just saying.
She's been around
really
for a
dating
while.
herself.
She still has split personality.
Just saying.
What's funny though, if you think about the LifePak 5 and then like the earlier iterations of the 10, and then they're adding on the 12-lead modules and all this sort of stuff as the monitors grew, look at Tempest and where they're at. It's like basically going back to that frame of mind or that point in time. And then now look what's happened to Tempest. They're having
I can tell in my office the LifePak 10, and you know,
Oh, yeah.
we're doing it way before the
That's
LifePak.
the one that they're getting away from at Medic.
Yeah,
They
Medic
went to
just
that just
swapped after they spent millions and millions of dollars on all those new Tempest Pros. They elected to spend another millions of dollars to switch them to the X Series Advanced because they were having so many issues out of the Tempest. Everybody back? Alright. We can join us back here in just a second. Alright, we're going to get back started. We're going to finish this up. We're going to talk about the waveforms, and then we'll follow up with some Q&A stuff towards the end, okay? So waveforms, there's actually a true anatomy to the Capnograph waveform. So when you're looking at this, you start at 0, which is your baseline or your phase 1. That's your dead space ventilation. Again, there's 0 gas exchange occurring. When you move into phase 2, this is what we call the expiratory upstroke or upslope. When you start into that phase 2, this is where dead space ventilation ends and you start getting mixed alveolar ventilation and your CO2 starts to climb. Then you move into phase 3. Phase 3 is your expiratory plateau. So with the plateau, that is true alveolar ventilation. That is where everything from the alveoli should be empty. This is where your end-tidal CO2 is measured. That specific piece of the waveform is most often where you can start seeing pathophysiologic changes. If you start seeing blunting of this angle over here, the alpha angle right here, you start seeing blunting of that, or it starts to decrease its slope, you start looking at that classic shark fin waveform pattern. We know that there's bronchospasm, right? Phase 4 is our inspiratory downstroke or the end of exhalation. As far as interpreting the capnograph, there's steps to this just like you would interpret an EKG, right? The easiest way to learn how to interpret an EKG is choosing a method that works for you, but then following that method every time. Do it the same way every time. Same thing for a capnograph. Question 1, do we have the presence of end-tidal CO2? Okay, then that begs the question, is this a circumstance where we should? It's what we're trying to monitor. Could it be that we're potentially in the wrong place? Step 2, do we see a rebreathing pattern or a walking baseline? You're going to see this in your obese patients, your patients who are pregnant. Step 3, respiratory upstroke. Is it normal? Does it look like a square? If you see prolongation or loss of that square waveform and it starts to look like that shark fin pattern, then we again know bronchospasm is the underlying problem that we need to fix. Step 4, look at the expiratory plateau. First off, is it present? If it is, this signifies complete alveolar empty, meaning everything that was in the alveoli is completely exhaled. If not, if the waveform looks different, then we have to question, are they truly getting their alveoli completely emptied out? We call it uneven alveolar empty. What are some examples that you can think of uneven alveolar empty? There's one real easy one, quick off the bat. Emphysema, and what's another one? Pneumonia. And then we look at step 5. So read the actual CO2. What is the number and what does it indicate? Normal waveforms are almost always described as having a normal expiratory upslope, normal alpha angles, appropriate expiratory plateau, appropriate beta angle, and then normal inspiratory downslope returning completely to baseline. And that's what it should look like, right? Pretty easy representation of a normal capnograph. Then we start looking at things that cause abnormal waveforms. So esophageal intubation is where all of the focus for this came into being back in 2010. But then we started adding shark fin for bronchospasm. And then we started looking at curare cleft for patients who are intubated requiring sedation and neuromuscular blockade. Then we added cardiac oscillations, looking for leaky airways, actually watching the CO2 change real time with interventions, and then looking at rebreathing patterns. So tube in the goose, or an esophageal intubation, that's what it will look like. Basically, it's a missed intubation attempt. What's a reason why we might have a little bit of CO2 reading at the beginning of this when the tube is placed? Carbonated beverages, yes, so sodas, beer, you name it. If it's carbonated at all or comes from a can or a top that you have to pop, you're going to have a little bit of CO2 in the beginning of esophageal intubation. And then it's going to very, very quickly go away, right? Because you're ventilating all that out there with the bag valve mask. You're not in the lungs. There's no CO2 exchange. All right? The other thing to talk about with this, capnography is as close to Jesus as you're getting, okay? Capnography doesn't lie. Capnography will not fail you. If it does, it happens very, very rarely. Usually, if it does, it's operator error. So if you have no CO2, you have no patent airway. We had this, this was another lesson one of my clinicians at home got to learn the hard way. I was working in the ED and he called in a report for a cardiac arrest. I don't remember what it was that he said on the radio, but I honed in on it real quick and I said, hey, what's your CO2? 0. You do not have a patent airway. Please remove that ET tube and place a supralevator. He didn't do it. Decided he was going to just continue to do things his way because he knows better. Came into the ED, rolled into the code room, same thing, end tidal of 0. I got the glide scope, took off into the room, shoved the glide scope down there, looked at it, hey, you come here, and he walked around. I said, tell me where that ET tube's at. He looks at the glide scope and said, that looks like it's in the esophagus. I said, yeah, your CO2 told you that about 25 minutes ago. The next time I tell you to do something, I'm not telling you to hear my head work. He had all the data he needed, and he just continued to ignore it. If your CO2 is 0, and you do have a good tube, what's the problem there? That code was never viable to start with. We probably got some rigor mortis somewhere. We probably should have done a little better than this. Bronchospasm, so again, going back to the classic shark fin terminology from back in the day, you can see on the far left what a normal Capnograph would look like. In a moderate obstruction, you can still see that you've got a pretty clear and concise alpha angle, right? Your upslope is increased, but you've still got a good alpha angle. Whereas the more severe obstruction you get, you lose that alpha. And then you can actually use that to be the judge of just how aggressive you need to be with your treatments. Curare cleft, so you can see the dip in the expiratory plateau. This is essentially the patient trying to take or initiate another breath in the presence of mechanical ventilation. This typically occurs because the sedation has worn off or the neuromuscular blocker has worn off. You see this a lot with patients who are given rocuronium, and then it starts to wear off and they're still inadequately sedated. So it's a good hint to, hey, you probably need to increase your sedation or manage that a little better. Paralytics are not always the go-to first line answer. It makes me cringe to go into a hospital and I ask, what have you given the patient for sedation? And they look at me with a big smile and say, rocuronium. Is that why they're looking at me? Did we think this through? That's pretty cruel and inhumane. That's torture. I mean, that's the equivalent of being buried alive. That patient's keenly aware and can't do anything about it. Let's back up and start with other medicines first. Let's look at fentanyl, maybe a benzo, maybe some propofol. Huge fan of propofol. I used to not be. I hated it. But it's turned on me the more I'm used to it. Cardiac oscillations, you can see this in hypovolemic states and in states of hypoventilation. Basically, each heartbeat's ejecting a small amount of CO2. Where do we see that now in our line of work? Where do we see that in the field? Because we don't have cardiac oscillating ventilators in the field.
CPR.
Yep, CPR. That's your biggest one. That's where you're going to see those waveforms. CPR. Cuff leak or an inadequate seal around the ET tube. Basically, the tube size is probably too small, or you actually have a cuff rupture. You can see that in the end tidal. So you can see you started with a normal waveform, and then you lost your expiratory plateau, and your inspiratory downslope was still pretty crisp. So you've got an issue with your airway. Med center air is actually a requirement for us for advanced airways that have cuffs. We have to measure a cuff pressure. And it has to be less than 30. That's your normal cuff pressure is less than 30. And we have to do whatever we can do to get that cuff pressure back down.
The last slide, the oscillation.
Mm-hmm.
I don't know how familiar you are with the LVADs. Do you see that with the
You can.
pulse-style LVAD?
Yeah, especially if there's a low flow alarm. So that's another good point.
Well, my wife takes care of those, but they got the pulsatile ones now that.
Yeah, so the new HeartMate 3s have similar pulsatility built into them, where the computer actually tells the device to basically ramp its RPMs up and down subtly to create a fake pulse. So yeah, you can actually see that with that.
Yeah, I was wondering.
So a good example of this, we went out to get a patient at Atrium Health Union that we were transporting, put the cuff flater syringe on there, checked the cuff pressure. The cuff pressure said OP for overpressurization. It started to deflate itself. I took about a half a cc of air out thinking, oh, that ought to fix something. Kept going and kept going and kept going until I saw my pressure get less than 30 and then noticed that I had a cuff leak. What was the problem? They had put a 6 OET tube in somebody that probably could have used an 8 OET tube. So the airway was just. Increasing CO2, so caused by a decrease in minute ventilation, increased metabolic demand, or sudden increase in your body temperature. So when your metabolic demand first goes up, one of the first things that changes is your temperature goes up, and then your respiratory rate goes up, and then your heart rate goes up, right? Think about the patient who has a fever. Your end-tidal CO2 is going to do that initially until the compensatory mechanisms kick in to knock it back down, right? To try to balance everything back out. So you can actually see this real time. The example that I gave of this morning, because it had been a while since I had actually seen one real time happen before my very eyes. Took my best friend's kid down to Brenner yesterday on a rescue squad ambulance. He's got some sort of undiagnosed bacterial infection, and he needed to go down there for further evaluation. His temperature at bedside when we arrived was 98.8. They had given him a dose of Tylenol at 2 p.m. This is 6:30ish in the evening. Get him in the truck, start down the road, start noticing his end-tidal goes up, his heart rate goes up, starts getting a little more tachypnic, check his fever, 103.7. So then we have to start back at square one and retreat everything. We've got Tylenol, Motrin, ended up giving him a dose of morphine and some Zofran as well. But one of the very first things that I noticed changed, it gave me the hint his fever was climbing or his temperature was climbing, was I saw the changes in the CO2. So that's actually seeing that metabolic demand change real time. Like I said, eventually the body says, I don't like this, let's balance it out. And then you kind of lose the ability to see that. But it's really cool when you get to see it right then there in the acute phase. Decreasing CO2 caused by an increase in minute ventilation, subsequent decrease in metabolic demand, decrease in body temperature, or low cardiac output states. You just watch it go off. Rebreathing pattern, that's what that looks like. Basically, you have that walking baseline. You start at a baseline of 0, and then with every breath, that baseline increases because that patient's not completely exhaled. Their breath stack. How do we fix that?
Would it depend if they're breathing spontaneously or not?
Spontaneously or not? Yep, that's an excellent question. And that's usually where we start at with these patients. Are they breathing spontaneously or not? If they are breathing spontaneously, what are we going to do to fix it?
System.
You can assist them, add PEEP. Essentially what's happening here is that patient's probably auto-beeping a little bit. So it may be that this is a case of obesity hypoventilation syndrome, and maybe they need a little CPAP to support them, to get them through it, to break the cycle. Very good. Capnography and cardiac arrest, adequacy of CPR. So if you have an end-tidal CO2 of greater than 20, then we're doing good chest compression, right? That's the general rule of thumb. That's what all the literature has supported. And that's one of the goals or one of the things we look at when we're looking at goals for resuscitation. What's our end-tidal? It's going to help us determine, do we need to change our compressor? Do we need to change our hand location and positioning? Those sorts of things. Now, what magical new device do we all have that has taken the place of the manual CPR? Our friend Lucas, right? Our favorite fireman. So we have the Lucas device on all these trucks, right? What's the issue with the Lucas device?
Yes, you have to read on potato.
Yep, you can get a CO2 reading pretty much anytime, any place. What else?
Doesn't fit everybody.
Doesn't fit everybody.
It's a Lucas.
It's a Lucas. You're breaking ribs, probably more so than you would with manual CPR, so you're already losing your chest wall compliance, so it's going to change the way that you have to do positive pressure ventilation and breathing. What else do you have to think about with this Lucas device? The number one issue that I see on scenes with Lucas devices is than not placing it correctly. You gotta make sure you get the placement right the first time. So apparently your striker rep is better than the striker rep that I had. But the striker rep that I had was telling everybody, oh, you mark the suction cup and that's gonna help you. If the device moves, then you know where to put it back. Well, that's subjective because that's assuming you placed it right to begin with, right? And it's not about the suction cup. That suction cup on the Lucas device doesn't make a hill of beans in the grand scheme of things. It's the piston. Where is the piston sitting? Is the piston actually sitting over the lower 1/3 of the breastbone where it's supposed to? Because the piston is what's driving the compressions, not the suction cup. So paying attention to that. If your CO2 is dropping, you may need to reposition or move your Lucas device. So what are some things that you can do to mitigate movement of said Lucas device during code? Neck straps, that's a big one. So use your neck strap. For the love of God, I know people have done it at home and it drives me nuts. Don't put this thing on a backboard. All you're doing is basically pouring oil on the floor and expecting yourself to walk across it without slipping. The patient's just going to slide it right off. It's not going to do any good. So don't use a backboard. If you're going to do an IO in the cardiac arrest patient for which you're using the Lucas device, what do you need to do before you drill them? Get the arms up in those Velcro wrist cuffs on the side. Because if you put a humeral head IO in with the arms flat and then you go to move them up, what happens? You bend the needle or you pop it out. So you got to be careful. Detection of ROSC, sudden increase in your end-tidal CO2 during the CPR is a marker for ROSC. Okay, well, we already hit on this briefly. What if the Lucas is doing really, really good compressions and you don't see that change? Rhythm checks are still something that you have to pay attention to. The other thing, and I've had this happen, ran a cardiac arrest call in Watauga County. It's out in the north end of the county, so a very rural area. First responders got there first, initiated CPR. This lady was a COPD patient who called 911. Essentially, clinical picture of COPD exacerbation. They lost contact with her. First responders arrived on scene, found her down. They initiated CPR. The EMS crew got there. They got on scene. They went in, threw the Lucas device on, put an IGL down, started an IO, and they were given their first round of drugs when I walked in the door. Walked in the door, asked, hey guys, what do you need? Where are you at? What can I do? Just kind of reassess everything, look over some things, see where we're at. This is what we've done, see what we're missing. Glaring abnormality, they didn't have the patient on capnography. So low hanging fruit, hey, throw capnography on that IGL up there. Let's see what we've got. All right? So in a cardiac arrest patient with an IGL in place, what would you expect their end-tidal CO2 to be? So right around 20, 25 maybe. This patient's was 78. So now how does that work for us to try to determine, do we have ROSC? Feel for a pulse, right? Well, she doesn't have a pulse. So her CO2 78, can we use end-tidal as a reliable indicator of ROSC? Probably not. In her case, she's hypercarbic from her COPD and the fact that she was exacerbated. The hypercarbia was actually the cause of her cardiac arrest. I ended up basically making people look at me like I was a crazy man with 10 heads. I looked at the first responder and I said, hey, I need you to bag that CO2 down to 50. He's like, you want me to hyperventilate the patient? Yes, I know that sounds crazy, but just hear me out. Just do it. So he did it. Bagged the CO2. We got down to like 52 and got ROSC. By the time we got her to the truck, she's moving her extremities and she's fine. So contrary to what we've been taught, there may be a time when we need to hyperventilate some of these patients. Termination of futility. If your end-tidal is less than 10 for greater than 20 minutes, that code's probably going to be one you could terminate in. Now, this again is completely dependent upon your protocol, what you're doing. In Watauga County, ours is based off of a rhythm. Basically, if they're asystolic and their CO2 meets these parameters, then fine, you can discontinue in the field. But up there, we do not discontinue EEA codes in the field. Those cannot be terminated in the field. Those all have to be transported to the hospital. We actually have a system in place where once we get them into room 9 there in the ER at Watauga, we're going to put ultrasound on the chest and see if we can identify correctable cause. We've actually had a couple of cases where we've been able to do that and completely reverse everything and the patient had a good outcome. So that's why we're not discontinuing EEA in the field. Special consideration, so head injuries. This is one of those things where we tag an end-tidal CO2 level to a clinical context, right? Standard of care has long been that magical 32 to 36 or 30 to 35, depending upon what textbooks you read, okay? So we were using end-tidal to gauge just how well we were caring for these patients. Now, we're striving to normalize the end tidal, not necessarily taking them all the way down to that 30 to 32. Because what we learned is for every decrease of your end tidal by 1, you reduce cerebral blood flow by 3%. So, if that patient has chain Stokes respirations or some other neurogenic breathing pattern and they're acidotic, and we put them on capnography and their end tidal is already 55, 60, do we need to take them all the way down to 30 necessarily to be able to reduce their cerebral blood volume enough to decrease their intracranial pressure and save their brain? No. Maybe normalizing the CO2 is all we need to do. Maybe only getting it to 40 is enough to do the trick. So that's why now you're going to start hearing that terminology change to, hey, just normalize the CO2. That's all we want to do. And then you can also elevate the head of the bed to 30. Again, causes of increased CO2, looking specifically at metabolic causes, you think about pain, hyperthermia, and shivering, respiratory system, respiratory depression and failure, or you've got an issue with obstructive lung disease. Talking about the circulatory system, increased cardiac output, where the actual tubing, plumbing, piping, whatever you want to refer to it as in your world, is actually intact and not leaking anything. And then equipment, defective exhalation valves or a kinked off circuit. We see this a lot in the aircraft where we start seeing these values change. It's like, okay, well, the patient's fine, we don't see anything else odd. We go back and start tracing the circuit back, and we find that, especially in the new aircraft, because there's cramped space on the rail, the circuit is kinked between the ventilator and the monitor. So we have to kind of move things around to relieve that obstruction and get it open back up. Causes of decreased end tidal CO2, metabolic causes, hypothermia, certain overdoses, diabetic ketoacidosis, sepsis. Respiratory, you're looking at alveolar hyperventilation, circulatory system, cardiac arrest, pulmonary embolisms, and decreased cardiac output. And then equipment, leaks in the systems, partial obstructions, where your ET tube has backed itself out into the hypopharynx. Capnography and opiate overdose. This is another love of mine. So let's talk about Narcan, the other drug I hate. It ranks really high with dopamine for me. I despise this drug with a passion. And every time I say that, a lot of people are, oh, well, you're not sympathetic to people who have addiction and those sorts of things. It has nothing to do with that. I want them to get all the help that they need, and if a lay person has to save their life with Narcan, that's fine. But we as clinicians know better, right? We have more tools. Pumping somebody full of Narcan is not going to help anything. Because who are they pumping full of Narcan? Every diabetic passed out in the Walmart parking lot, right? That's who's getting Narcan. Pumping all this Narcan into patients who don't need it. So did anybody get a memo where we changed ABCs to NABCs? I missed it if we did. I did not get that memo. It is not Narcan airway breathing. And that's the downfall of a lot of things. I run into this at home too. I get out there and my firemen are very quick to empty boxes of Narcan into the patient. One of my very best friends is a cop. I ran an overdose with him one time. He gave a dose of Narcan, and when I walked in, he had another prime ready to go, and I legitimately looked at him and said, if you push that, I'm kicking you in the head. Don't do it. You probably don't need it, okay? Manage the airway. That's where the $1 million fix is here, right? Airway breathing circulation. Simply putting somebody on a non-rebreather mask or assisting their ventilation with a back valve mask and an OPA or an NPA may be all you need to do the trick. One of the last overdoses I ran at home was this girl. It was her first overdose, allegedly Percocet. She was supine in the floor. She was apneic. People thought I was crazy, but I had to wait for them to prove it. Her first pulse oximetry reading was 14% with a good pleth. We got an NPA in, started bagging her, got the end tidal primed up and ready, threw it on there. Her CO2 was 79. In the course of bagging her on high flow oxygen, SAC starts rising. She starts spontaneously breathing on her own again. We eventually get her to the point where I put in a line and I gave a measly 0.5 of Narcan, and she was right as rain after that. She had her little initial wake up and freak out phase, but hers wasn't freaked out because we took away a high and she wanted to kill us. It was more of she's just woke up and there's 30 strange looking men in her living room and she doesn't understand why. That's where her anxiety. We explained to her, well, honey, you were dead 5 minutes ago. She completely changed her tune. She was willing to go wherever we wanted her to go, and we were able to get her to the hospital. All right, so talking about that, what are the hazards of Narcan? What are some side effects of Narcan? We're always taught that Narcan is this safe and effective drug. Nobody talks about the nastiness of Narcan. Pulmonary edema is a good one. That's a good place to start. You do get some non-cardiogenic pulmonary edema from Narcan administration.
When you give a lot of doses, they throw up and compromise their airway.
Bingo. Increased risk of aspiration pneumonia and pneumonitis.
What?
So that creates a whole new problem for us. What else?
Hot-tempered people keep not feeling.
Yeah, that's a side effect. We'll call that a side effect. My favorite symptom that nobody ever attributes to Narcan, and it's like one of my favorite educational pieces about Narcan. How many times have you given excessive doses of Narcan and then the patient has diarrhea?
Oh, no.
Yes. High dose Narcan causes diarrhea.
Okay, so now you just made me want to give even less than I already do give.
Yes, exactly. And I'm not saying this, to dissuade you from giving it, because I still give it from time to time. But it is a legitimate issue with Narcan, especially in high dosages. So what happens is you give the high dosage of Narcan, they start having diarrhea. What happens when you start having diarrhea? You lose what?
Water.
Water. When you lose water, you lose what else? Electrolytes. So you take your electrolytes and you kick them through the floor. One of the first times that I ever remember giving this lecture at bedside, we went to Atrium Stanley to pick up a patient who had been overdosed. EMS had given 12 milligrams of Narcan prior to arrival at the ER. First off, let me tell you, if you are actively doing CPR, Narcan is useless. It does not work. Concentrate on your airway. That's the whole ship of opiate overdose is done, come and sailed. Okay, you missed the boat. See you tomorrow when Carnival returns to port.
Every time you go into Lincoln, did you give Narcan?
Yeah. Well, I was telling him this morning, Dr. Henderson was sitting here. I was the bane of my medical director's existence because I hated Narcan so much I would just tube him. You're breathing 2 times a minute. I don't need a sedative. I don't need a paralytic. Happy to go to the ER. And then my medical director was like, "Why are you the way you are?" Because you let me be. What else do you want me to tell you?
So about 15 years ago, this is while I was at North, we had a batch of heroin come through one weekend that was cut with glucophage. You want to talk about OD patients that had already lost control of everything? It was disgusting.
Yeah.
With glucophage? Yeah, they cut it with glucophage. And so everybody was OD, they were unresponsive at making the shit results. Yeah.
See, I don't think that's what you meant when they made the him wait in the water.
Remember the system song when I came back.
Yeah, there you go. So, yeah, it does happen. So this patient, they were like, yeah, her potassium's 2.6. I'm like, well, yeah, because it's all over the bed.
So my question is, how rapid is the onset of the diarrhea?
Usually within about 30 minutes.
30 minutes?
So
Drops like that.
I had it happen then, and then one
Don't
of my
worry
last
about
ER shifts, my medical director was the attending, and we had an OD come in, and I kept begging her to just tube him. So she's giving Narcan, EMS is giving Narcan. At this point, we're at like 6 of Narcan. We took him to CT, got him over there, we brought him back, and I called her from CT before we left. I was like, this guy needs to be tubed. I'm not continuing to do this. This is ridiculous. Just put him down in the bed. We get over there, and I had her convinced to do it. She had everything set up. She's ready to go. I don't know why, but at the last minute, Jenny talked herself out of it and said, oh, let's give him some more Narcan. So at that point, I washed my hands of it. I walked out the room, went back to the nurse's station, sat down, and started the charge. Within about 15, 20 minutes, somebody walks by the room, and they're like, what's that all over the floor in there? I look across the desk, and I'm like, oh, it's Narcan. He shit himself. So he had massive diarrhea from the high dosages. It can happen. So be mindful of that. Because not only do you now have a primary electrolyte imbalance from that, but what happens in the post-arrest patient when you're trying to correct their acidosis? You're driving that potassium even further through the floor. That was the issue with the patient we had at Stanley. The patient's potassium was 2.6. I asked for a potassium infusion when he left. The physician argued with me and would not let me have it. Get CMC, as my luck would have it, Dr. Swanson was my attending in the ED at CMC that day. So I rolled in, presented said patient, and he's like, well, why did you not get potassium? Well, A, I don't carry it, and B, your little boy up at Stanley didn't want to do it. So they repeated his labs, and the potassium level was 2.3. So, in fact, worse. So now we could be rearresting this patient and transporting him. So it's a double-edged sword. Basically, the point being, everything we do, we have to do it with thoughtful intent. We don't just do it because we can. Is it really indicated for the patient, and is it something that we really need to do right here, right?
Well, the whole thing with, yeah, I know that's what one of the biggest complaints is with law enforcement. Well, maybe part of part too, that they have no way to manage that airway.
Well, the police departments don't, but the fire department.
The fire department,
Yeah.
They're gonna be together. So that's the thing with the law enforcement, cause they're taught not to give it unless they're not breathing.
But they still give it even if they are.
So,
Oh, I threatened to take it away at home. I told him, I was like, I'm gonna take your Narcan away, and the only thing we're putting in the patrol car is a PVM and an AED.
See, can we just give them AEDs?
They don't.
Right?
We're trying to, but that's a lot of money, there's a lot of deputies out there.
Can we just start with the BDMs?
Yeah.
At least we've tried that as well too.
Yeah,
but-
but they
Yeah,
in
in
Georgia.
most
Y'all can't be blaming
cases,
the fire
they're
department
not
for
nurses,
everything.
sergeants.
Y'all gotta take some of this responsibility on yourself.
Do we?
So one of the things going forward that I would propose, and we had this discussion this morning, I'm a guy, I was anti-EMS research until I got involved in it, now I really love it. So if you know rich people who want to throw money away, I'll gladly take it for research purposes. Because one of the things that I now question with this is, why do we give Narcan titrated to a respiratory rate? Why not give it titrated to an end-tidal? Because the end-tidal is what's going to tell us what our respiratory rate is. Because 8 breaths a minute might be perfectly adequate for somebody to ventilate so long as their end-tidal is normal. Yeah. Because what happens if you wake them up? They fight. And I don't know about y'all, but me and myself, and as long as I've done this, burnt out EMS Nate comes back real quick. Have you seen Bringing Out the Dead, Nick Cage? I'm Nick Cage. That's how the last little bit of my EMS career was.
That was homework for some of my people on my shift, was like Bring Out the Dead.
Yeah, like I got low tolerance for certain things. My general rule of thumb is if you treat me with respect, I'll treat you with respect. But if you're gonna wake up fighting me, game on. I'm gonna defend myself.
Rise up, I'll be down.
Huh?
I said, rise up, I'll be down.
Well, we had a double overdose at home one time, and this one EMT, he had been talking for a while. He's like, I hear working with you is fun. I was like, be careful what you hear and how you interpret it. So we get out on the scene where it's a dual overdose. We've got 2 patients. Law enforcement, of course, has pumped everybody full of Narcan. One of them is taking a little more work than the other. And I'm sitting between the 2 patients, because I'm the only medic on scene at this point, trying to help direct care of these 2 until the other truck gets there. The guy on my right legitimately sits up, and you can tell by the look on his face, without missing a beat, this EMT says, I looked at this guy and said, I'll kill you just as quick as I brought you back. And he just laid back down. So Max still tells that story to this day. He's like, that was my introduction to Nate. He said, I thought that was pretty cool. And then I had to work with him a little while longer, and I questioned the sin. Which, if we work EMS, I'm sure there's a lot of people that question.
Don't look at me. I'm the sanest person I know.
Are you asking yourself that or people?
It didn't sound very
No
convincing.
comment.
All right, so then methods. Most monitoring systems that we're using now are revolved around microstream technology. We have invasive and non-invasive methods. So looking at your connectors, how many of you remember being told at some point in your education that orange meant adult and yellow meant pediatric? Did you guys ever get that? Because I did. I learned recently we're wrong. Orange is for short-term use. That's probably what you're going to see predominantly in the EMS world, or it's flavor of the week and whatever you can get that's not on back order, right? Because everything's perpetually on back order these days. So your orange short-term use filter lines, it's quick seal connection, single twist. You get a tight seal with the monitor. There is a small filter in there, but they are much more prone to failure with prolonged use and condensation, airway secretions, those sorts of things. Whereas your yellow connector, these are your long-term use ones. Those are actually better. They have a more robust filter. They last longer. They are less susceptible to dealing with all the condensation, airway secretion, all those sorts of things. So they last longer. And then lastly, capnography placement's like real estate. It's all about the location and where you place the device to read it. Close to the site, exhalation as you can get it, is where you want to be. Nasal cannulas are best for most applications, so don't be afraid to use them, even if your supply guy argues otherwise. Invasive end-tidal monitoring lines are best for intubated patients or those requiring assisted ventilations, and that actually needs to be directly on top of the airway unless you have an HME, so a humidification and moisture exchanger device. Then you put that on there, and then you put your CO2 on top of that, because that humidified moisture exchanger is actually going to keep your invasive capnography device from being filled with saturations and liquids and all that sort of stuff. Summary, this is now the standard of care. This is no longer something that we use as a select special application in our patient populations. There's really no reason why we shouldn't be using this. another diagnostic tool in our toolbox that helps confirm the suspicions of our assessment findings. It's an excellent predictor of what's to come. Like I said, it's a predictor of ICU admission, hospital length of stay, and mortality. And we have to be able to recognize both normal and abnormal because this really can make a difference in our patients and how we treat these patients in the field. It's going to help guide our decision making. Any questions, comments, or other remarks?
And y'all can ask him anything, doesn't have to be about capnography, anything about Med Center Air that you want to know.
Yep, I'm all ears.
We certainly appreciate you for coming and sharing the information and doing it in a way where it was entertaining.
You're very welcome. I try to be entertaining because I remember what it was like sitting in that chair and being bored to death. I didn't always have a sense of humor either. That's the other piece of the puzzle. I've lightened up.
If you will, go over the information that we talked about.
Yeah. So one of the questions that came up in one of our previous discussions where we were talking about this was the interaction of the flight crew on scene and how we like to get our reports. So if you guys have been around long enough to see the Metrolina Trauma Group post all this stuff about the MIST format, that is very much what we like to use. We use the MIST format. So kind of the anatomy of a scene call for us, and one of the things that we teach our new hires is there's actually an art to what we're doing once we arrive on the scene. So if both people charge into the ambulance at the same time from all fronts, you're more likely to get two different people giving two different versions of the story to two different people, and then none of it ever meshes or meets in the middle, right? A lot of things get lost in translation. There's a lot of miscommunication that comes up from that. So typically what you're going to see us do is whoever's getting in the back door of the ambulance first, that is who's getting a report from you guys. So the way they do that is they get in first, and then whoever's assessing, there will be a little bit of a pause before they come through the curbside door. So whoever's getting a report hops in the back, all focus on them, give them the report, let them have the story, and then whoever's assessing comes in from the curbside door and we'll start an assessment from head to toe. And usually whoever's doing the assessment is going to be who's intubating in most circumstances. Just depends on how the call falls out regarding your experienced providers and who else there, who else not. So once we're in there, what we like to look at is that MIST format. You guys are our eyes and ears from the flight crew perspective. Because do we always land directly on the scene? No, a lot of times we're at the hospital helipad or we're in a field 3 or 4 miles down the road from the scene, so we don't see all the same things that you guys see. So the M in the MIST acronym stands for mechanism. So we want to know what the mechanism of injury is. If it's a motor vehicle accident especially, you guys saw it. So we want to know what you saw. You know, we get the basic stuff. Patient was the front seat restrained driver, or they were unrestrained, the airbags deployed, or that sort of thing. But we want to know more. Was there space intrusion? Did this patient require extrication? If so, how long did it take them to extract the patient from the accident? Was the windshield damaged? Was the steering wheel bent? Steering wheel bent is a little less common these days with the advent of new vehicles, but I did have a kid back in February of this year that I actually just had the pleasure of meeting. He survived after in my brain I had written him off for dead. He had a bent steering wheel. That was one of the very first things I noticed about his truck. I was like, that's a bent steering wheel. You don't see that anymore. That's significant, and it was significant. Luckily for him, he survived completely intact. He's done well and is at home, basically returned to a fully functional life despite all of the things that have gone on. But being able to paint that picture for us so we can kind of see through your eyes what you saw and be able to place things into perspective at the scene. So from there, we move into injuries. When we're talking about injuries, I don't care about the 355 lacerations caused by glass shards. I really don't care about that. I want to know the big ticket items. What are their pupils? What does their chest look like? What does their abdomen look like? Is their pelvis stable or unstable? And what are their long bones? And then what's their neurological assessment? Those are the big pieces of the puzzle that I'm after. Because that's going to tell me real quick, like, what I need to have in my brain for interventions on scene, right? Because one of the things that you guys might be doing is decompressing that patient. That's a critical skill, right? That's a high acuity skill. That's not something to be taken lightly. That tells me just how injured this patient is just by knowing that right off the bat. So if you can give us the big ticket injury items, it's going to help paint that picture even more. Moving into the S, those are your vital signs. So if you've ever been to CMC and you've given a trauma report, they like highest heart rate, lowest blood pressure, best and worst GCS. They want to know about pulse oximetry reading. They're probably going to ask you about your first or second born child and do you have a name and date of birth, right? That's all the things they want to know. For me, I'm perfectly content from the flight side, and most of my flight colleagues would probably agree. I want to know what their current GCS is. I want to know what their highest heart rate is, and I want to know what their lowest systolic blood pressure is. Because if you give me the highest heart and the lowest blood pressure real quick in my head, I can calculate a shock index, and that tells me just how far down the tube this patient's gone. It's going to help me determine, do I need to bring my blood products out of aircraft? I work with a lot of wonderful people, but we all have some sort of syndrome where we forget crap on scenes, right? So a lot of them have the mindset that they don't want to take the blood cooler out of aircraft because they're afraid they're going to leave it. Well, what if I need that blood product right then and there? What if I do need to take this airway? If I need to take this airway and I don't resuscitate this patient with blood products and they needed it, Dr. Swanson is going to have my hind end in the scene. I don't know about y'all. I don't like being in Principal Swanson's office at 7 a.m. Okay, it's not my favorite place to be.
It's not that.
He's not that bad. He and I have gotten to know each other really well and have a wonderful working relationship, but there are still some things I just don't want to do. I made one of the ED physicians at Huntersville laugh one morning when I called him Principal Swanson because he wanted me to crock a patient bouncing down the interstate. This patient had a foreign body airway obstruction, basically a razor blade stuck inside the glottic opening. And I was like, let me tell you what I ain't doing. I ain't doing that. If you want her crocked, you can go in there and do it. But I ain't doing that bouncing down the highway, and I sure as heck am not going to visit with Doug Swanson as soon as I pull in the ambulance bay at CMC. It's just not happening. Principal Swanson's not my favorite person to say that. And when I said that, he's like, that's funny, I've never heard that. I was like, I don't find it humorous right now. You need to go use the airway. I'm not doing it. We ended up managing her airway with Ativan and fentanyl. That's how we kept her calm, copacetic, had a good entitled, good sat. We got her down there and then we let her get it. But as far as your vital signs go, especially the highest heart rate and lowest blood pressure, it tells me a lot about what I need to know in that moment to prepare for that patient. And then treatment, I don't need to know every little piece of information about the treatment you've done. Again, big ticket items. That they've got a C-collar in place. If you've done a chest decompression, that's great. If you've got your vascular access, tell me what you've got. If you've got a pelvic binder in place, those key pieces of information, because again, that kind of helps me paint a picture in my head of just how sick this patient is. All right? And then stroke patients, if you're flying any sort of medical patient, it's kind of the same format, but you change it up to the nature of illness and the pertinent things from the medical side of things. All right? Vascular access, one note about that we've talked about on and on, or off and on when I've given this lecture. I am not huge on the whole 14, 16 gauge bilateral AC thing. The trauma team loves their 16s. What do we know about starting IVs in the field, right? What do they teach us in textbooks? What angle do we approach this vein at? 45 degrees. The textbook lied, right? Because how many times have we approached that at 45 degrees and we've blown every attempt we've tried? I would 10 to 1 rather have 2 functioning 18 gauges than get on scene and you failed an attempt at a 16 gauge 5 different times. And if they're really that bad, guess what else we've got? A little DWALK drill somewhere sitting in a bag, right? Don't be afraid to start that IO. Because guess what we're going to do when we show up? We're probably going to start that IO if we feel like they need. That's the big thing for treatment. If you do a needle chest decompression, again, let us know very quickly that you did it. Landmarks can be an issue. Nothing makes me question life more than waking up at 6 or 7 in the morning to a text message from a resident in the CMC ER, and it's a picture of 12 different catheters hanging out of someone's chest wall, and they proceed to tell me that Med Center Air did it. So my first question is not why they did it. My first question is, where the hell did you find 12 needles? Do we only carry 2 on the aircraft? Were you just darting them with lawn darts and IV catheters randomly out of the IV kit? Or how are we doing this? Because we don't carry 12 needles, all right? If I'm on the aircraft, we have 4, 2 in the bag and the 2 I keep in my flight suit. That's pretty much it. You're not going to find 12 needles, okay? So then I have way more questions about how this really went down. Dr. Swanson had the same reaction. He was like, what the hell is this? We actually didn't M&M about it. The lesson learned was if you think that you need to decompress it many times, go to ER and get a chest tube. So again, painting a picture of what interventions you've done is paramount to helping us kind of paint a picture of what we need to do next. Pelvic binders, when in doubt, place them. You're not going to hurt them. Make sure they're placed appropriately, though. They're not tunnel bones. They don't go up here. They go right across the hip bones. Any other questions? Forgot to mention it this morning, but worth noting, if you guys are interested, the Ride Along program is back post-COVID. Under the weight of 240, you can come fly along with us. If that's something that you would like to entertain doing, medcenterAir.com, scroll all the way to the bottom of the page, the release of liability form is down there. You just fill that out, email it back to me, and we'll get you scheduled. We'll try to keep you at the base closest to your residence. I know Hickory base is the closest base for you guys. If you do come do a ride along, I'm probably going to try to put you at the Hickory base, because right now the Hickory base is our busiest aircraft. They're turning 60 flights a month on their hub, and they're going everywhere. It's no longer just our normal little service area of Caldwell, Catawba, and Lincoln, and the occasional Iredell. We're picking up at Dow, we're picking up over in Spruce Pine in Mitchell County. We're going back up to my home up in Boone and over in Avery County. So you never know where you're going to end up. They are the busiest aircraft in the fleet. They very rarely see the airport unless they get work.
I'm in my house at least 3 times a day.
Yeah, it's that busy. And Concord's picking up a lot of the things that Hickory would normally do when they are busy. And Concord, they've not come right out and said this, but I imagine that Concord is going to become a dedicated specialty bird in addition to its normal duties. The reason I say this is we already are the primary bird for NICU most of the time. So the other thing they're doing is we're getting our own balloon pump up at the Concord base. So that pretty much tells me that we're probably going to go do all those trips as well. Which at Concord, it's kind of weird. At Concord, you have your most experienced clinicians, the ones that have been there longest. With the exception of myself, I've been there for 4 years. Most of your seasoned veterans are in the base. And if you try sending anybody else, I can tell you this from working in the charge role, if you try sending anybody else, they call them, I'm not comfortable. Okay, say no more. You're not going to learn unless you go do them. You've got good people with you. You just got to step up and do them. All right. Any questions, comments, other remarks?